I am audible. Am I audible loud and clear? Am I audible? Can you hear me, everyone? Okay, good. Right. So, acromegaly. First of all, before we start up with acromegaly, let me just recollect what we have the last two classes. We were looking at the hypothalamus, pituitary, adrenal axis, but here let us look at the hypothalamus pituitary axis. And as we know, we have the hypothalamus, which sits at the base of the brain, and this is influenced by most of the neurons, and this is basically the hub of the endocrine system. And from the hypothalamus, we get, from beneath the hypothalamus, we have the small pituitary gland, which has two parts in it, which is the anterior pituitary and the posterior pituitary. The anterior pituitary is basically connected with the hypothalamus through the vessels. So the hormones which are created like from above are pushed down through the blood and are stimulated through the anterior pituitary. Whereas in the neurohypophysis or the posterior pituitary is almost like a direct connection between the hypothalamus to the posterior pituitary by neurons rather than through blood vessels. So basically this is called as neurohypophysis, and the anterior pituitary is basically an adenohypophysis. Adenohypophysis, basically the hypothalamus stimulates, like sends in some hormones to the anterior pituitary. These are the gonadotropin releasing hormone, corticotropin releasing hormone, thyrotropic releasing hormone, prolactin releasing hormone, and growth hormone releasing hormone. When these come and stimulate the anterior pituitary releases FSH and LH, ACTH, TSH, prolactin, and growth hormones, which act upon the target organs like the gonads. The ACTH acts on the adrenal cortex, the TSH acts on the thyroid, the prolactin is helpful in the mammary gland to let out milk, and growth hormone acts on the liver and all over the body for the general growth. The posterior pituitary, which has basically the ADH and the oxytocin, is basically a neuronal connection between the hypothalamus and the pituitary, and just sends the signals which are from the from the hypothalamus to the posterior pituitary and to the adrenals, or to the catecholamine system. So this let out to the target organ, the kidney and the mammary gland, which is helpful for contraction of the uterus and the let out of milk. So what is acromegaly? Acromegaly is a slowly progressive disease resulting from the increased release of growth hormone and consequently insulin-like growth factor 1, most often by a pituitary adenoma. Usually this is from a pituitary adenoma. So gigantism occurs when growth hormone excess leads to increased linear growth before the end of puberty and epiphyseal closure. So in children, we call it gigantism because where there is a linear growth, the epiphyses haven't fused yet, and there will be an increased spurt of growth in these individual long bones, thereby the person reaches becomes pretty tall. They can reach up to 7-8 foot also. This is called as gigantism. And when we have in adults wherein the epiphyses have already fused, it is not possible to have a linear growth in the long bones. In such an individuals, we have acromegaly, wherein you have dense features due to growth of the overall growth, what we call as a general growth. Acromegaly occurs when the growth hormone excess is present in individuals after epiphyseal closure. That's what I've been just telling you. So this is one simple to look at the etiology. I copied it from Davidson itself. So where do we get the growth hormone from? So primary growth hormone excess, as I told you, is the most common cause for primary growth hormone excess is an adenoma in the pituitary gland. So in the pituitary gland, we have a tumor which secretes excess growth hormone. Okay. Before we say so, we need to know some few important things. That what stimulates growth hormone? Growth hormone is basically stimulated by what we call as growth hormone releasing hormone from the hypothalamus. Other than that, growth hormone is also stimulated by other factors like low sugars, hypoglycemia, increased amino acids, increased fatty acids, and exercise. These are the four things which stimulate the growth hormone. That is why when we exercise, we ask the children before epiphyseal closure, we ask the children to exercise so as it releases a little bit of growth hormone that would help in increase of height. So growth hormone releasing hormone. Other than that, we have the other four factors which can stimulate primary growth hormone excess, like the growth hormone from the pituitary. And when this growth hormone is released into the circulation through the anterior pituitary, it reaches the liver. Most of it reaches the liver, where it is metabolized and it releases something called as insulin-like growth factor 1. Insulin-like growth factor 1. This insulin-like growth factor 1 from the liver and the growth hormone itself from the anterior pituitary helps with the somatic growth metabolism. So it causes somatic growth metabolism dysfunction, wherein you have an excess. So we have a pituitary adenoma, we have a pituitary carcinoma, we have extra pituitary tumors, and some familial syndromes. Last week, we were talking about some multiple endocrine neoplasms and McCune and Albright syndrome and familial acromegaly. These are the common factors wherein you have a primary growth hormone excess. So other than the pituitary, sometimes tumors from other places, like tumors which occur in the lung, can also produce growth hormones. So these hormones either are not from the pituitary, but from the extra hormone, from the extra tumor we have. The tumors release growth hormone, and these also act in the same way, like pancreatic islet cell tumors, lymphomas, iatrogenic, and also sometimes with lung cancers. These can produce growth hormone. And growth hormone releasing hormone excess. This can happen sometimes when an excess growth hormone releasing hormone is released from the hypothalamus itself, wherein it causes a somatotroph hyperplasia. So what is a somatotroph hyperplasia? These cells which produce the growth hormone are basically somatotroph cells which are present in the anterior pituitary. So somatotroph cells which are in the anterior pituitary are stimulated upon either by a tumor sitting in the pituitary or from a tumor sitting outside the pituitary, like in the islet cell tumors or in the lymphoma or in the lung, or it can be sometimes a growth hormone excess, growth hormone releasing hormone excess, which can stimulate the somatotrophs from the anterior pituitary. So what happens when this growth hormone is released in excess? So when this is released in excess, the growth hormone per se helps with it reaches the receptor situated over the muscle. And this, one of the major function of growth hormone is the protein metabolism, wherein it converts the amino acids, converts them into muscle mass or into protein, where you have hypertrophy of the muscle or the organ. Even not only the actin, myosin, even the soft tissues also increase in size. And most of the hormone reaches the muscles directly, and some hormone reaches the liver, wherein it is metabolized by the JAK-STAT pathway. If you will look into the JAK-STAT pathway, and when eventually it produces a insulin-like growth factor 1, which is released into the circulation, and this again helps in the bone growth. So when we have an excess of growth hormone, what happens? First signs are acral dysmorphia. Acral, that means hands. Acra, that means limbs. Dysmorphia, disfigurement, or like change in the size of these dysmorphia. You start having wide hands and feet. The fingers are broad, stubby fingers and toes and thickened soft tissues. So if you look at for the one, that's why most of these people initially notice their change when the ring they're wearing doesn't fit or the shoes don't fit anymore. So the size increase in the size of your shoe, increase in the size of your ring should make you suspicious of acral dysmorphia or acromegaly. Facial dysmorphia. Multiple changes happen in acromegaly, like in this disease of acromegaly in the face. So first and foremost thing is when you look at the face of such a kind of patient, it's very classy. You can't afford to miss it. You have a rectangular face, a very coarse skin, with which would be greasy, and there would be the person would be having the sweating. They would have an enlarged and widened nose with the prominent cheekbones and a bulging forehead and thickened lips. Usually it is the lower lip that becomes much more thickened compared to the upper lip, and wrinkling of the skin. The jaw protrudes forward, what we call as the prognathism, and maxillary widening. Maxilla is widened, and teeth separation, because the jaw is increased in size and the maxilla is increasing in size. You won't be having the teeth which do not increase in size but remain the same size, so they get separated from each other and cause widening between the teeth. That is, there's teeth separation and jaw malocclusion. The lower jaw protrudes forward, thereby when you close the mouth there is a malocclusion of the jaw. Non-specific symptoms, one of the second most important is there's a second initial complaint that comes with the patient for the patient comes with is headache. It is because of pressure. The tumor sitting in the pituitary can cause pressure symptoms, therein by the patient comes with a headache. Asthenia, fatigue, hyperhidrosis, increasing sweating, acroparesthesia, that is pain in the palms and soles, usually carpal tunnel syndrome, and joint pains. Joint pains, usually patient get involved, larger joints are involved, large joints are involved, and usually are non-inflammatory type of joint pains. Non-inflammatory type of joint pains involving the large joints and causing pain. For a quick recap, so what are the clinical features? Physical changes. There's a prominence of the brow. You notice that the brow is prominent. Prognathism. As you see in this individual, there is a prognathism, that is protrusion of the lower jaw. There is macroglossia. As I told you, soft tissue hypertrophy can also lead to macroglossia, where you have a big tongue, and hyperhidrosis, excessive sweating, enlargement of the nose. Here do you look, there's a widened and big nose, and soft tissue and lips. As I told you, the lower lip is involved, soft tissue hypertrophy, and acral overgrowth. This is acromegaly. See, notice the difference between the two hands. This is acromegaly, wherein you have stubbed short fingers, but they are thick and coarse. And metabolic and endocrine complications, you have impaired glucose tolerance, and patients develop diabetes mellitus or insulin resistance. Patient develop dyslipidemia and sometimes goiter. Gastrointestinal complications are colonic polyps. You find polyps all throughout the colon, top to bottom, involving the colon, and you may develop polyps leading and sometimes adenomas, tumors, small tumors sitting in the colon, and dolichomegacolon. That is, you have a long, big colon. Dolicho is long and mega is big. Dolichomegacolon. And coming to the reproductive disorders, you have menstrual disturbances because of pressure symptoms and adjacent hormones being involved. You will have menstrual disturbances, and in men, patient may be having erectile dysfunction. As we know that the adenoma in the pituitary is located just beneath the optic chiasm. So when you have a tumor sitting just beneath the optic chiasm, and it causes pressure over the optic chiasm, so it causes a visual impairment, typically of what we call as the homonymous hemianopia, wherein the person will not be able to see what's in his both lateral fields. That means both the temporal aspect of the visual fields are lost. That kind of visual impairment may be present. Patient would have pressure symptoms like headache, and because of pressure over the posterior pituitary stalk, your patients would be having hyperprolactinemia and hypopituitarism. Coming to the cardiovascular complications, patients would be having hypertension. Patients will have biventricular hypertrophy. A biventricular hypertrophy, because of increased hypertension, patient would be having excessive growth of cardiac muscle also, wherein they show a biventricular hypertrophy and they develop a obstructive or sometimes a hypertrophic cardiomyopathy, and eventually can lead to congestive heart failure and arrhythmias. Valve disease like prolapsed valves can be noticed in some cases. Prolapse of valves. Coming to the respiratory complications, patients would be having upper airway obstruction, and because of the macroglossia or the tongue falling back, and patients sometimes develop hoarseness of voice because of the vocal cords becoming thick and swollen. Ventilatory dysfunction would be there, as the patient would have difficulty breathing because of the upper airway, and also the lung capacity would increase. And sleep apnea would be noticed because the patients would have edema like swelling around the neck and the upper airway, and the patient would be having a big tongue. Excessive snoring, obstruction caused due to obstruction. When you come to the skeletal system, patient would have increased articular cartilage thickness. As I told you, this hormone can produce what we call a stimulation of osteoblasts, osteoclasts, and also the proteoglycans and the cartilage forming cells, wherein thereby causing articular cartilage thickness. Arthropathy would be there. Patients would complain of large joint pains. Large joint pains, non-inflammatory, large joint, non-inflammatory kind of pains. And because of the osteoclast being predominant, and sometimes the bones become very fragile and can cause pressure fractures, what we call as vertebral fractures. Patients would have paresthesias, and because of compression, they can cause carpal tunnel syndrome. A few patient pics of, just to make sure. This is a very classic picture of this patient. You see, he has a big nose. You can look at the rectangle type of face. A prognathism, the chin is protruding out. Increased lower size of the lower lip, and increased brow. The same as with this person also. This is prognathism seen in a kid. Macroglossia and acromegaly. So now that we have made a diagnosis clinically, now we need to look at investigations. What do we know? What do we do to investigate? Simple is measuring growth hormone levels during an oral glucose tolerance test and measuring serum IGF-1. Okay, we'll make it fast here because I think I repeated a few of, okay. Measuring growth hormone levels and serum insulin like growth factor 1. Normal plasma growth hormone suppresses to below 0.5 micrograms per liter approximately, or 2 milli international units per liter. As I told you, hypoglycemia triggers production of growth hormone. So if you give a glucose challenge by giving glucose, the growth hormone is supposed to go down. So if it suppresses, if you give glucose, your growth hormone suppresses to below 0.5 or 2. If it doesn't, that means it is elevated. The growth hormone is elevated. Growth hormone does not suppress in about 30% of patients. There's a paradoxical rise. Okay. So measurement of serum IGF-1 levels. Measurement of serum IGF-1 levels is the first line biochemical diagnostic test. Okay. This is more important than measurement of growth hormone, because this is one-time test, because you need not take multiple readings like in growth hormone. You just have to do it once. If it is a growth hormone, you will have to take multiple readings to make sure the growth hormone is elevated. Okay, and measurement of plasma IGF-1 levels is recommended in patients with typical clinical manifestations of acromegaly. If the patient has the classic features of acromegaly, we can measure IGF-1. In patients who do not have the typical manifestations, but have associated conditions like obstructive sleep apnea, type 2 diabetes mellitus, debilitating arthritis, carpal tunnel syndrome, and hyperhidrosis and hypertension, all the remaining features, even though the patient doesn't have acromegaly. And those patients who have a pituitary mass, you'll have to do a insulin like growth factor 1 level estimation. This is the first line biochemical diagnostic test. IGF-1 measurement is simpler than growth hormone because it only one blood sample is required and which can be obtained at any time of the day. Growth hormone varies from across the day. Like for example, growth hormone is seen least in the early hours in the morning and is maximum during sleep in the night. So that is why most probably adults say that kids grow up during their sleep. That is, kids increase in size when they sleep more. So IGF-1 measurement and above average serum IGF-1 concentrations are encountered in above average are seen in normal pregnancy, puberty, and post-pubertal period. We have to take caution of that. And below average are seen with uncontrolled diabetes and renal failure. And as I told you, measurement of growth hormone levels, why we don't show much interest is you'll have to take multiple readings, and the basal level of growth hormone in the serum in the morning or sampling at random times is elevated in acromegaly. So in the morning, as I told you, it has to be low. If it is elevated, it means the patient is having acromegaly. The diagnosis of acromegaly requires measurement of growth hormone added during a 75 grams glucose load. As I told you, when you give a glucose load, your growth hormone goes down. But if it doesn't go down, if you give glucose, your growth hormone has to go down. So if it doesn't, if it is more than 0.4 nanograms per ml by ultrasensitive growth hormone assay or 1 nanogram per ml using standard assays, that means it is elevated and the patient is can be diagnosed with acromegaly. In up to 30% of patients with acromegaly, growth hormone levels paradoxically increase. That is, as I told you, in response to oral glucose. That is why oral glucose, post-glucose growth hormone estimation is not much advised. We always look at insulin like growth factor 1 levels. And other additional investigations, we look at prolactin concentrations are elevated in 30% of patients due to co-secretion of the prolactin from the tumor. And additional tests in acromegaly may include screening for colonic neoplasms. As I told you, you can have plenty of adenomas all throughout the colon with either by doing a colonoscopy. MRI. Okay, MRI is one standard test which we need to order because we have a pituitary which is situated in the pituitary fossa. Once a diagnosis is made, workup focus on tumor mass effects such as changes in the visual field and acuity. You look for visual confrontation test and visual fields are mapped, and if you find there is visual field effects, you'll have to go for an MRI. MRI provides information about the size of the adenoma and its invasiveness. Microadenomas, 20% of cases are visible as homogeneous, well circumscribed, rounded images, and generally slightly hypointense on T1 weighted sections. After gadolinium injection, that is after giving a contrast, they appear hypointense only. Microadenomas, 20%, and They are well circumscribed and slightly hypointense on T1 weighted. Give gadolinium, they still appear hypointense. Macroadenomas are usually isointense on T1 weighted sections before gadolinium injection, and whereas the lesion appears hyperintense after gadolinium. This is how we differentiate between microadenomas and macroadenomas. If an adenoma is not obvious by MRI, or if the pituitary has an asymmetrical bulging hyperplastic appearance, then acromegaly is secondary to ectopic growth hormone releasing hormone should be suspected. So once we don't find an adenoma sitting in the pituitary, once the pituitary has been ruled out, then you start looking for extra pituitary sources of growth hormone releasing hormone secretion. As I told you, you'll have to look for something high up in the hypothalamus in the brain, or it can be due to pancreatic islet cell tumors or a lymphoma, or it can be from the lung. So how do we manage acromegaly? As we know, we have this tumor sitting in the pituitary. If it is because of a pituitary adenoma, microadenoma, we do a transphenoidal surgery. This is the first line treatment. You go through the nose, through the sphenoid and sphenoidal sinus, and reach the pituitary. Usually, most of the bulk of tumor is removed by this method. And if it is anything remains, we do an external radiotherapy is usually employed as second line treatment if acromegaly persists after surgery. Coming to the medical management of acromegaly. Medical management, if acromegaly persists after surgery, medical therapy is usually employed to lower growth hormone levels. So you have to bring down the growth hormone level to below 1 microgram per liter. That is approximately 3 MIU per liter, and to normalize the IGF-1 concentration, because IGF-1 is made from growth hormone. Somatostatin analogs. As I told you, the cell which is produced, cells which produce the growth hormone in the anterior pituitary are the somatotroph cells. So, and somatostatin analogs like octreotide, lanreotide, and pasireotide, these are slow release injections every few weeks have to be given and used as primary therapy for acromegaly, either as an alternative or before the surgery to shrink the size of the tumor. Somatostatin analogs are one, and dopamine agonists. Dopamine agonists are less effective at lowering growth hormone, but may be helpful, especially when associated with prolactin excess in such situations. Pegvisomant. Pegvisomant is a peptide growth hormone receptor antagonist. A peptide growth hormone receptor antagonist administered daily when if there is a failure of somatostatin analog therapy failure. Thank you. Hope there are no questions. Okay, then we leave. Thank you so much.